A good morning, a good afternoon. Thank you all for joining in to attend today's important session. Our online audience, thank you for registering in. And we have the in-house audience who are the experts. Our session for today is, the topic is undifferentiated fever. As frontline health workers, every day we attend to patients who come in with fevers. Many are straightforward, but others may be difficult due to undisclosed cause. Today, I have experts who are going to take us through the session to help us know how to approach undifferentiated fever. Before we go through the session, I will introduce myself as the moderator, and I'm privileged to be here. My name is Halima Adam, a nursing officer working with Mubende Regional Referral Hospital, and I'll be moderating through the session until the end. With me here, I have experts whom I'm going to request to introduce themselves. And we have two experts who will be joining us online for the session. I'll start with one of the experts on my extreme right. You're kindly welcome and introduce yourself.
Thank you. Good afternoon, everyone. My name is Dr. Aine Alice. I'm a pediatric resident at Makerere University.
To my left.
Thank you so much. You're all welcome. Osira John Andrew Mulago, critical care nurse. Over to you.
Good afternoon, everyone. My name is Dr. Andrew EMT Naguru Kolan Dispatch. Thank you.
Thank you, our in-house experts. Now I take the honor to welcome our online experts to kindly unmute and introduce themselves. We have Dr. Pascal who will be joining us all the way from Gulu. I hope she's there.
Thank you very much, moderator. Thank you, colleagues who are already on this call. I'm Dr. Pio Pascal. I'm a consultant physician at Gulu Regional Referral Hospital. I'm happy to participate in this session today. Over to you, moderator. Thank you.
Thank you, Dr. Pascal. Dr. Gomesiriza, are you online? Thank you.
Yes, I am. Yes, I am. Good afternoon, Sister Halima. Gumisi Norbert is my name, psychiatrist, all the way from Kabale. Greetings from this side. Thank you. Kabale Regional Referral Hospital and Kabale University.
Thank you, our experts. We also have Dr. Chris. He's not yet online. Dr. Chris will be responding to our chat questions. Will be introducing himself when he is online. Next, after the introduction, we are going to have our expectations as well. Of course, joining in and registering in. I know we had expectations for the sessions. I'll request 2 or 3 participants to, by show of hands, to tell us their expectations, and the rest kindly post your expectations through our chat, and they'll be responded to. Thank you. Yes, and expectations for this session, as I earlier introduced, the topic is undifferentiated fever. And our experts will be taking us through. We shall have a case presentation. After the case presentation, then we shall have other sessions flowing in and questions. Kindly share with us your expectations for this session. Let me request Alex. Alex, are you there? Ndelema, to kindly share with us your expectation for this session.
Thank you so
Alex?
much, please. Thank you, Doctor. Hope I'm audible.
Yes, you are able enough.
My expectations are for the discussants to help us dissect through the different causes of undifferentiated fever, and also how to approach a client who has undifferentiated fever, how to investigate them, acute management and long-term management, follow up, basically until they improve. Thank you so much for the opportunity.
Thank you so much for sharing us your expectation. Any other participants who like to share with us his expectations or expectations? Let me request Natume Aisha. Natume Aisha, are you ready to share with us your expectations for this session? Yes, meanwhile, let me request Rule Colin. I see he has raised up his hand. Rule Colin, kindly unmute yourself and share with us the expectation.
Hello.
Yes, hello, we can hear you. Yes, Lule, Colin. You're not audible enough, but you can continue. Okay. So, okay. Thank you all for responding to for raising up the expectations. So at this moment, we are going to proceed with our case presentation. We are going to request Dr. Alice Aine, who is a pediatrician and child health resident at Makerere University. Dr. Alice, kindly take us through the case presentation.
Thank you very much, Sister Halima. Thank you very much, Sister Halima. My name is Dr. Aine Alice, and I'll be taking us through the case presentation for today. I'm presenting a 4-year-old male, no known chronic illness, who had lost his mother and newborn sibling to unknown febrile illness a week prior to admission, was referred into Mulago National Referral Hospital due to persistent high-grade fevers that had lasted for 1 week and had reduced levels of consciousness for 2 days. On primary survey, the airway was patent, but was threatened due to reduced levels of consciousness. Breathing, there was in mild respiratory distress with nasopharynx. Respiratory rate was 56 breaths per minute, and SpO2 was 80 to 90 on room air. On auscultation, had echo air entry, bilateral bronchovesicular sounds, and there were no any other added sounds. Had cold extremities, and the capillary fee was more than 3 seconds. The heart rate was 160, which is tachycardia for a 4-year-old. BP was 78 out of 45, which is low. GCS was 10 out of 15 with eye opening 3, verbal 2, motor 5, and pupils were equal and reactive to light, had normal tone and normal reflexes. RBS was normal for 4.6 millimoles per deciliter. Patient was febrile with a temperature of 39.5 degrees Celsius. No rash initially, but later developed ecchymosis and oozing from vein puncture sites.
Yeah, thank you. Our audience, we have a poll question there for you to answer. And from the primary survey, what are the 3 emergency conditions in this patient? Can we all send our answer through the chat? I can see a number of responses are coming in. Thank you. Okay. Let's continue with our responses through our chats. So far, I see the highest percentage is 59, still going up, who have responded with the answer of threatened airway. The 3 emergency conditions in this patient. So you have 2 minutes to close the poll and we continue with our case presentation. Finally, let's continue responding through the chat. I see 139 total responses out of 244. Okay, let's continue responding. (142) out of 224. We need more responses to that question. So we are closing the poll and we are continuing with the case presentation.
Thank you. So from the primary survey, the emergencies in this patient, we had a threatened airway due to reduced levels of consciousness, meaning the patient was at risk of aspiration. Possibly a patient could have air obstruction and due to the reduced SpO2 of 88 to 90, could be at risk of hypoxic cardiac arrest. So what was done to secure the airway and then started the patient on oxygen therapy. The other risk was a septic shock in view of the cold extremities, delayed cap refill, and a tachycardia. The associated risk with this could be a multiple organ failure due to compromise. So we established IV access for IV fluids and resuscitation and initiated the patient on broad spectrum antibiotics. So about 5 hours later, the patient started convulsing. The convulsions were generalized tonic-clonic and bleeding from the nose, mouth, ears, and this increased a suspicion of a possible EBV. So
next, we have a second poll question. Based on the above information, what are your emergency management priorities for this patient? Let's kindly post our questions through the chat. So the question is, based on the above information, what are your emergency management priorities for this patient? There's only one correct answer. I can see responses flowing in. One minute to go. Based on the above information, what are emergency management priorities for this patient? Number of responses are flowing in. Now we are at 121 out of 245. Let's respond before we close and continue the presentation. Which 115? So 448 responses, 150. So we are proceeding with the presentation. Thank you all for the responses.
So based on the above information, patient at emergency department was given oxygen via nasal prongs, started on IV fluids at 20 mils per kilogram of normal saline, was started on IV ceftriaxone at 80 milligrams per kilogram. Blood samples were taken off for CBC, malaria tests, serum electrolytes, LFTs, and culture. Patient was isolated in view of the history of unexplained febrile death of the parents and the sibling. Infectious disease team was consulted so that we rule out a possible viral hemorrhagic fever. So with more history, patient had fever, reduced level of consciousness, there's also a history of vomiting. There are no known allergies. I'd received 2 cycles of atosinate from the referring hospital, but there was no any reported clinical improvements. Past medical history, this patient had no known chronic illness. To admission, had last fed via NG tube about 3 hours prior to admission. For the possible events leading to the presentation, we think the patient was exposed to the mother and a newborn sibling who died of a febrile illness, and at that time they were living in a high-risk area for possible infectious disease. For secondary survey, on examination, the eyes were sunken, neck was stiff, chest was clear, normal breath sounds, increased respiratory efforts. Abdomen was soft, non-distended with a hepatomegaly of 5 centimeters. The skin was initially normal, but later bruised and had petechiae, bleeding from cannula sites. On your exam, patient was drowsy, non-verbal, and was responding to pain. Relevant negatives, there were no focal neurological deficits, no signs of trauma, and no abnormal heart sounds.
Our third poll, what are your top 3 differential diagnosis to this patient? What are your top 3 differential diagnoses for this patient? Kindly post all your answers in our chats, and Dr. Chris will be responding to all the questions. As our audience and all participants are responding to our poll questions at this moment, I invite Dr. Chris to kindly unmute and introduce himself. Dr. Chris.
Thank you very much, Halima, for the introduction. Sorry, I'll just unmute. And my name is Christopher Nsereko. I am a consultant physician, but also in infectious disease. I'm based in here in Entebbe. I'll just put my video. I'm just in the office. And then, yes, it's based in Entebbe Regional Referral Hospital. Thank you for having me. I'll be responding to all the queries in the chats. Please keep them coming. Thank you.
Thank you so much, Dr. Chris, for all the responses that are coming in through the chats. Back to our poll, I see we have 180 out of 263 participants, and we shall be closing the poll in the next 1 minute so that we continue the presentations. Let's continue responding to the poll question. What are your 3 differential diagnoses for this patient? So at this moment, we are closing the poll, and I get back to our quickest presenter to continue the presentation.
So the differential diagnosis for this case, we'll categorize them in different systems. So for vesicular, we think this patient could possibly have disseminated intravesicular coagulopathy in view of the bleeding tendencies. Wanted to rule out a possible infectious disease, or top of the list would be possible viral hemorrhagic fever. In view of the bleeding tendencies, fever, and high-risk area at the time. Severe malaria with cerebral involvement, because this patient had been treated for malaria with 2 cycles of assessment with no improvement. The other differential would be possible meningoencephalitis in view of the reduced levels of consciousness and fevers. Autoimmune disorders could be possible necrotizing encephalomyopathy in view of the reduced levels of consciousness that had happened just over 2 days. Also wanted to rule out electrolyte imbalances in view that were possibly causing acidosis in view of the reduced increased respiratory rate and the distress. So the investigations that were asked for at the time, we asked for a complete blood count, to rule out any infections, blood smear for malaria parasites. We did renal function tests and extended electrolytes because this patient had reduced urine outputs. We did liver function tests in view of the hepatomegaly. We request for a brain CT scan in view of the reduced levels of consciousness, and then real-time PCR for Ebola to rule out Ebola, since the patient was being highly suspicious of Ebola. So the workup was done. Full blood counts, white cell count had a leukocytosis of 11.5 with a normal neutrophil count of 2.62, with a lymphocytosis of 7.41. HP was also low of 8.9. Platelets were low at 90. My RDT was negative. Random sugar was normal at 4.6 millimoles per liter. Electrolytes and creatinine had an elevated urea of 70 milligrams per deciliter, and creatinine was high at 655, which is almost 4 times higher than normal. LFTs, the liver enzyme test, the enzymes were elevated. ST was 696, ALT was at 855, GGT was 668. So at that moment, we thought this patient is probably having multi-organ damage because the liver is affected, the LFTs are affected, and the Then in suspicion, patient samples were taken off for PCR, and the PCR test was done, but only on postmortem due to suspicion, and it was positive.
Thank you. Let's continue with another poll question. Based on the above laboratory results, what are your next steps in the management priorities for this patient? Let's keep on sending our responses through our chats. Based on the above laboratory results, what are your next steps in the management priorities for this patient? You can see the responses are really coming in. So far, 144 out of 292. $164. Thank you all for the responses. $172 response. So the question is, based on the above laboratory results, what are your next steps in the management priorities for this patient? $188 response out of 292. Let's continue responding. We have 1 minute to close the poll. So we have 198 out of 300. We are closing the poll. Thank you all for responding to the question. Let's continue the presentation.
So the management for this patient was mainly supportive. Received isotonic fluids that was normal saline at 20 ml per kg bolus. That's because the patient was in shock from the beginning. We also had to reinstate maintenance fluids to continue management of dehydration. Patient was supposed to be monitored every 15 minutes. Initially started on antibiotics, that is paracetamol, 15 milligrams per kilogram. In view of the bleeding tendencies, patient was transfused with platelets and fresh frozen plasma at 10 ml per kilogram. When the patient started convulsing, was started on IV phenobarbital, received 2 doses at 80 milligrams per kg. A catheter was inserted to monitor urine output. Ization with strict barriers was initiated. So patient was because in the country at the moment we did not have any antivirals for Ebola, so patient was not started on remdesivir, but support care was continued on hydration, oxygen, and transfusion. Infection control was reinforced. The family members and the staff that were exposed to the patients were quarantined and monitored for any signs of Ebola. So patient died within the first 24 hours due to excess bleeding and convulsions, and so we did not follow up to do a brain CT scan to know, since the patient died before some of the investigations were done. Thank you.
Thank you, Dr. Alice, for taking us through the case presentation. That was an interesting case who came in with fever, but kindly just type all your questions through our chats about the case presentation. Will be responded to by Dr. Chris. Next, we have the hospital team. Mr. Okuro will be taking us through what we need to prepare for pre-hospital care for this patient. Mr. Okuro Andrew, as I introduced earlier, is a pre-hospital provider EMT at Naguru Call and Dispatch Center. We're kindly welcome to take us through your presentation.
Thank you so much, moderator, and thank you so much, Dr. Alice, for the presentation. My name already has been said, Okuro Andrew, and I'm going to share about the hospital care and evacuation of this patient. So as we've just seen from the display there on the previous slide that was there, in pre-hospital care, everything rotates within the staffing, patient, the equipment that you're going to use, the mode of transport, and documentation and handover, which is, as we can see from the far right of the slide, we have a standard way of doing it. So basically, everything revolves within this slide. Next slide. My major points I'll discuss today in this session is for us to understand how we decide to transfer a patient, because by the time we arrive at a decision to move a patient from one facility to another, you have to make a decision, and this decision, how do you make it in EMS? Then also to understand how to prepare patients, because most of the times it's not just picking a patient from one place to another because they have to go. There are key stakeholders in the movement, so they really have to be involved in the movement and prepare them and plan with them, then we move. And then finally, each time there's an activity is done, usually we need to have reviews for quality improvement and monitoring, and just make sure that everything is always improving. Next. Yes, in this case, so this was a patient, a 4-year-old, this is a child who presented in the facility with undifferentiated fever. And the diagnosis was not known at that time. And again, as we see from this case, by the time EMS now comes in, we are not responding in a context of an outbreak. We're just going to pick a case. For purposes of just knowing more about EMS response in disease outbreaks, such as Ebola outbreak, for example, we have had echo sessions here previously when we had the recent outbreak in Kampala. So I'd encourage you to go back and follow on YouTube and try to look at those sessions and get the details of how we evacuate a patient during an outbreak, for example, Ebola outbreak. We've had the sessions here before. So today I will stick to, this is a call that has come in, undifferentiated fever, which could mean Ebola, any kind of infection, because Ebola is an infection. So today we're just responding grossly to a patient who has an infection. We don't know what the infection is. For such cases, of course, again, like I said, how do we arrive at a decision to transfer? So before we transfer a patient, we first need to define clearly what is the reason for transfer. Does it mean this patient will benefit from a higher facility? So that's a key question to answer. And then the other thing is, as you pick the facility you're going to, would it be a question of the facility? It could be at the same level of facility, but perhaps one facility does not have the equipment that the patient would benefit from, like a CT scan and so on. So those are the key questions you have to answer. Next. And then the other thing is, before even you start thinking of moving the patient, another key important question to answer is, will the patient actually even benefit from the transfer? So we do a risk-benefit analysis. And this will mean if you're very sure that this patient in the next few minutes of trying to move will not make it, then there's no need of wasting resources and time to move a patient who might not make it. For example, a patient is very critical, the patient is unstable, and the ambulance is limited with the staff, including equipment, and you're going to move a patient from, let's say, Mbara all the way to Kampala. So you have to anticipate the arrival results. How do you think the patient anyway make it? And then lastly, on preparation, it's very important to discuss this case with the receiving facility. Always notify the facility that is receiving. So this can be a discussion between the referring facility and the receiving facility, which are depending on the discussion they have, if they feel they deem it fit to co-opt in the call and dispatch center, because they're the ones who coordinate the EMS to be part of the discussion, that can be determined by them. However, if they call and haven't co-opted EMS in that discussion, EMS will always process the call and try to get all the necessary information that they need to know about this case so that they can relate to their teams that they are dispatching so that they know the information. But again, the other important thing about this is that if the call is coming from the community, so in this case, it's almost like the EMS then is the referring facility, because this patient is just in the community there, maybe on the roadside or at home, not seen by any health worker, no documentation and so on. So in this case, the EMS becomes the referring facility. Next. Yes, so now when this all is done, you've known the kind of patient, you're sure the patient will reach where you're going, you've notified the receiving facility, and they have assured you they have space. Now this is a very critical patient. They have to prepare all the necessary resources the patient can need. And when that all is done, then you have to now engage the patient. Let them know what is the next step in terms of their management, because I'm sure you all believe that referral is part of management of the patient, and all is done for the benefit of the patient. So you have to communicate, involve the patient, the referral, seek their consent. It's very important. So this is a child. You have to involve their relatives or their attendants and tell them this is a patient who needs to be referred, seek their consent so that they can be able to accept. If they decline, then there's no way you can force them to jump onto your ambulance. Of course, the consent can go to the next slide. Of course, the consent will involve other issues to do with giving them necessary information before they can decide. For example, where are they going, the reason, basic reason as to why in lay terms, why you're taking them and why you think they need to go. So when this is done, then they have to accept. If you convince them and they decline the transfer, so you have escalated and inform the dispatch that the patient has declined the transfer, they have right to their movement, and there's nothing you can do. And there are various types of consent there. I'll not go into the nitty-gritty of those. Let's go to the next slide. Next slide. This is only what I want to talk about because this is a child. Each time we're dealing with children, again, like I said in a few seconds ago, we have to involve the next slide, the attendants. Back. Yes. So this was a child. So and children usually we consider them as a special population. So each time we're moving a child, always we have to move a child with their attendant. You don't just move children alone. Again, a question of if you're suspecting this is an Ebola, an outbreak has not yet been declared, but if you suspect this is an Ebola, or if it's an outbreak, in this case, it was one time discussed here. We do not put someone that you suspect with another person. We don't put them together. But before you move them, of course, you will have seek consent and inform them of where you're taking them. Next. Yeah, so then when they accept that, okay, now we're ready to go, then you have to notify the team that is going to evacuate the patient. In notifying them, you have to give them necessary information that you collected during the process of receiving the call. So this is the call and dispatch that ensures this is done. You inform the team, then the kind of patient they're going to pick. Now this is a child, so they know which equipment and things they need to put in the ambulance as they're going to move this child, including the staffing level. So you need to know which team are you going to entrust this child with, because care has to be there en route. So you have to pick staff that really can be able to support this child who was in distress and in shock and needed some care en route. And also the kind of ambulance itself has to be now determined at this point. So you have to dispatch, now for this case, we would really need a type C ambulance. For the benefit of understanding what type B ambulance is, I refer you to the Ministry of Health ambulance norms and standards. It's a very detailed document with all the details of what kind of classes of ambulances that you have. So when this now is done, then before moving the patient, you have to make sure that the patient is stabilized. The stability of the patient is usually something that it's common, and again, from the case presentation that Dr. Alice shared, it's the same thing that is done here. So follow the ABCD approach and ensure that all the life-threatening conditions are sorted and addressed before the patient is loaded into the ambulance for movement. Next. Yeah, exactly. Stabilize the patient. So when the patient is now stable, this could be a patient maybe who could be on facility equipment, maybe connected on a monitor, ventilator, connected on other facility equipment, infusion pumps, etc., and so on. At this point, you on preparing and stabilizing, before you take off, after disconnecting the patient from the facility equipment and connected to the ambulance equipment, it's important to give some lead time to ensure that the patient remains stable before taking off. And then also in preparing the patient, still the patient has to be accompanied with the necessary documentation. This will include the referral form priority 1, which indicates the medication and the care the patient has been on. And then the other important necessary documents, this patient was investigated. The CBC was done, they had done the malaria, RFTs, LFTs, etc. So any investigation that is done for the patient, labs, ONL, radiology, imaging, things that were done on the patient usually should be accompanied in one file with the referral form. And if it's community, in this case, if this was a community pickup, then the only referral form you would have would be the patient care forms. Next. Then we start the journey. So en route care has to continue. However, as we all know, this is common knowledge to us. Anything not documented is not done. This I can't emphasize it further. What I can only just say about it is that we usually encourage in EMS and the hospital teams, and I think across the health divider, we do not only document the good things that we've done for the patient, but we also encourage to document the bad ones as well. Anything can happen, a mistake can be made, sometimes it can be unintentional, especially when in a high stress environment, having a very sick child, you can, at some point, we're all humans and mistakes are tagged to us, the same mistakes are humans. So if that has happened, we accept it, and conceding it actually displays a sense of maturity. You document that. So we encourage documentation of mistakes as well. And this has to be very clear. And then on arrival at the receiving facility, the handover has to be done. So the patient has to be handed over to a facility, and there's a standard way of doing that. So there's a standard guidance on how you can do that, the ISBA. I'm not going through the necessary details of it due to time. But importantly, the verbal handover has to stick to specific necessary things, then has to be accompanied with all the documents of the patient. Next. I just talked about the ISBA. Next. Yes, so after handing over the patient on the ISBA, recommendation is very important. So the aspect of a patient being febrile, and if you had your For example, you suspect this patient to be having a hemorrhagic fever that you've not yet known. So it's important for you to inform the receiving facility what you're querying, such that they can be able to prepare an isolation for you before you arrive. So after that, that is now done. The patient has been received. So then what next? Still handed over the patient at 2 p.m. and duty is ending at 8 p.m. So it's important to inform the call and dispatch that you've handed over the patient successfully or unsuccessfully. Important. Again, whether it's successful or unsuccessful, communication is very important. So they can know that now you're ready for another call. The documentation, all that is done, you need to do it. You need to, after that, prepare the ambulance for the next case. So this means replenishing, putting in the used up equipment that you previously used for this patient, decontaminating it, because now you've just moved a febrile patient, and in your movement handling this case, you thought this patient would be having this is an infectious case. You do not know what it is, but you think it's an infectious case. So this has to, the ambulance has to be well decontaminated. Again, the process of decontaminating the ambulance, now to do it better, we've had those sessions here before, and I would interest you to go back and continuously review them and watch them and get to know them better. And then lastly, especially, again, I emphasize this, errors can happen. So it's always very important to debrief. The debrief, especially for cases that are very complicated, for cases where you either register the death or even a near miss, it's always very important to debrief. And the whole objective for debrief is not to put anyone at fault on spotlight, but to appreciate what did go well, what needs to be improved, and how to make the system better. And the results of debrief can be shared with the entire team, so that if there's another person who is going to go through the same experience that the previous team had gone through, in the debrief session, they can be able to have already got an understanding of what the other previous team had, the experience they had, then they can respond better. Lastly, as I end my session, the take home here, I summarize it into 3. Very importantly, notification is very important. Each time you're moving a patient, the receiving facility has to be notified. It's very important, so they can prepare for you. This is a patient who, inpatient, you think this patient is really having an hemorrhagic fever, for example. VHF, this is what you think. It's important for you not to expose the receiving facility, notify them that I am bringing this person and this is what I think about, and so on. It's very important to document always. This we encourage this. It's very, very important to document and communicate. And always, okay, yeah, so it's always very important to document, and always preparation. Again, this is what I just discussed. It's very important always to prepare. Emergency responsibility preparation. Yes, thank you so much for listening. Over to you, moderator.
Yeah, thank you, Mr. Biro, for taking up through those important points on patients transfer. I hope you will take a note of that. This moment, I welcome the next presenter, that is Mr. Osiro John Andrew, critical care nurse, and he's going to take us through the nursing priorities for this patient during inpatient stay. And Mr. Osiro, most welcome.
Thank you so much. Yes, Osiro John Andrew, critical care. I see you specifically, Amlago. Thank you, my former presenters and experts. Andrew has brought me a patient. We have received the patient in the hospital, be it in the unit, in the ward, or up to the ICU. How do we manage this patient? What are my priorities? Before I start the slides, I was discussing with the doctor who was quarantined, and he told me, please, next time don't send us nurses or doctors who are not ready because when they sent a nurse to check his vitals, the nurse was so scared to attend to the doctors and the nurse and fellow colleagues. So the nurse, whether it's a nurse or a doctor, whoever is going in should be mentally prepared. They should be ready. They should really accept that I am going in for this. So preparation always. Let us begin with a mental preparation. We shall, the next presenter will talk more about that. Thank you so much. Let's start the slide. In the nursing management, I'm going to talk about, we have already seen the presentation, how the patient was, our 4-year-old, and what this patient had. Thank you. Yeah, so I am having this 4-year-old who, during my presentation, we assessed having a nursing diagnosis where the patient had impaired gaseous exchange related to the reduced level of consciousness, the GCS being 10. What are my goals? What do I look at? What do I want to achieve with such? I will definitely need to have my oxygen improved. I want to maintain a normal saturation. And then when I come, what do I want to do in maintaining that? Investigations that I would love to sit down. I want to begin by blood gas. What else does the nurse wants to do immediately? You want to position your patient. You want to do suctioning. I'm going to talk more about this. You want to also administer whatever prescribed drug that the doctors are prescribing. You want to, then we come to what is it that the ABGs are going to do. They are going to provide insight in the respiratory efficiency and severity of this gaseous exchange. We have already seen the patient, his SATs have dropped below 90. So when I position you, what am I going to achieve? It's going to help improve on the ventilation and decrease on your work of breathing. Our semifowler, all nurses across the globe, we all know that. Medications, what are they going to help us in this patient? We want to see the patient reduce on the airway resistance, therefore enhancing the gaseous exchange. At the end of the day, end of my shift, what do I want to see? I will have achieved, there's oxygenation will have improved, and the patient is going to be stable, hence overcoming my hypoxia. Next slide, please. This patient actually, if it was the potential, let's go back. The potential diagnosis, it will be, no. Back. Yes, this patient is having active bleeding, not risk. This patient is bleeding as we have seen in the earlier presentation, where there was vomiting, bleeding, and other things that were presented. So what goal do I want to see? I need to ensure that I want to ensure that bleeding is reduced. How I'm going to continually monitor my vitals to stabilize and make sure through vital monitoring and checking. By doing what I'm going to be doing next, we want to give this patient meds that are prescribed as stipulated in the slide. We want to vitamin K transnemic acid. We want to, as a nurse, I also want to make sure that the doctor, among the treatment he is writing, we need to correct the platelets, which can be a long-term thing. However, the blood investigation should be done ASAP. Monitor this patient, monitor vitals. What is the rationale of all this? So whenever a patient has increased heart rate and orthostatic changes, this is going to accompany, definitely you'll have the patient bleeding. Then a spontaneous bleeding can also occur. We saw the patient's platelets were below 90. It was 90. So all that, those are all triggers. So we need to stabilize and make sure our platelets are stepped up to our normal ranges. So when we monitor vitals, it's also going to help us detect and manage the potential adverse reactions. At the end of my shift, what has been my short-term goal to achieve? I want to ensure that bleeding at least has reduced within my first few hours of my shift. For my long term, it's going to be, I want to terminate bleeding. When my results are out and back, I want to ensure that my platelets are within my normal range. Hence, bleeding will be totally terminated. Next slide. Next diagnosis is going to be this patient being that they have been vomiting, They are in shock, and the capillary refill is poor. They have a touchy. So this patient is going to be in shock, where we also saw that this patient had a multi-organ failure. My goals, I want to reduce and prevent this so that it doesn't worsen. So we come to, what do I want to do to achieve this? I need to monitor as a doctor, as a nurse in my shift, monitor daily weight. Some decreases may occur, especially my urine output may gradually keep dropping. So nurses, that's why we need to keep documenting every output. There are insensibilities that we normally neglect. Document them, have them jotted somewhere where they have to be. Then at the end of the day, you have to balance it up and monitor the patient closely for cardiovascular overload. Sometimes with the doctors prescribe, give these liters, you may end up over-voluming your patient, and you may find that the patient has maybe they are distended jugular vein and there's pleural edema because we have over-volumed the patient. So what are the rationales for me doing all this to prevent shock? I want to prevent preventing shock is crucial because it can lead to serious injury or death, whereby vital organs end up being deprived what? Oxygen. At the end of the day, I want to ensure that during my end of my shift, I have totally terminated shock. Next slide. We have a risk for fluid volume deficit related to restricted oral intake, bleeding, and vomiting. This patient was received NG tube in place because the patient dropped in GCS, which was 10. So we've had to find ways of feeding that patient, but still it is hard to jot that if you're not in a critically ill unit where we are closely monitoring you. So in this, I want to restore my normal body fluid volume. What am I going to do here? Restore the normal body fluid. My patient has an NG tube. As the doctor prescribes, I need to be feeding this patient 3 to 4 hours, depending on what the patient needs and what exactly the doctor has prescribed. If they are on IV, Carbiven, Omapon, and NG tube, where we normally give them Nutricorp, we make sure they receive what they are supposed to receive at the exact time. Normally we infuse it, we run it through an infusion pump to make sure the patient is not depleted what they are supposed to receive. So what are my rationales? Restoring the normal body fluid volume is crucial to maintain proper organ function to enable my vitals be stable within normal ranges. So by the end of my shift, at least within the 24-48 hours, there should be a normal body fluid volume that is restored. Next slide. As we're coming to the next slide, nurses should be monitoring, should be very close, because most of us, we always just want to do and we always forget to document. As my colleague had said, whatever is done, and we always tell this to students, and you don't document, is something that is not done. Next slide. Thank you. So always put emphasis on documenting whatever you are doing. So I will not deny the fact that this patient is not in pain. Truly, among other things, what we have here is the tachycardia 160. I put their facial grimaces. You can, patients who are unconscious, you can find a way of stimulating and knowing that this patient is in pain. This patient received paracetamol IV for the temperature as a double, also it's a pain med. So we want to relieve this patient from pain, and also my rationale of this providing rests when this patient, let me say, is in the unit. Then the ICU, you make sure they have rest where they have to be, make sure they are relaxing, and give appropriate meds as recommended. If those who are on infusions, ensure they're on infusions. I remember the patient we received in February, who caused chaos. It was too much. The patient was tubed and was on multiple meds, including fentanyl, which is a very good sedation, but mainly a pain med. So what is my rationale here managing my pain? I need to make sure Relief from pain in Ebola patients is crucial part in supporting the care, aiming to improve comfort and potentially to aid their recovery. So at the end of my shift, I want to see that my patient has reduced or completely no pain in them. Next slide. I want to thank you for listening. Over to you, Dr.
Thank you so much, Mr. Osiri, for taking us through the key nursing points to put into consideration when managing such a patient. Next, we have a presenter that is Dr. Norbert Gumisiriza, Head of Mental Health Department at Kabale University and Kabale Regional Referral Hospital. He's going to take us through the psychosocial support during epidemic response. Doctor, you're most welcome.
Thank you. Thank you, Halima. I'm not sure, maybe if you could get to the next slide. I had sent Jimmy other slides. Can you hear me, Halima?
Yes, we can. You're audible enough.
Okay, so no, these are different. Can I share the ones I have?
It's fine.
Okay, thank you.
Yeah, you have 20 minutes for your presentation.
Okay, I'll use less, I'm sure.
Good.
Can you see now? Kindly confirm, Halima, for me if you can see. Hello, Halima, can you see my slides?
We can see.
All
For us,
right,
we
thank
can
you,
see.
thank you.
Yes.
Thank you.
Presentation.
Thank you, thank you. Good afternoon, everyone. Dr. Gumisiriza from Kabale. I'm in the wilderness, so you'll forgive the birds and whatever you're hearing. So when we talk of mental health and psychosocial issues, we're simply talking about those three aspects. The mental is what one feels, what one thinks, what one behaves. And then the psychosocial aspect is how we relate with others, the family, friends, support, community. Okay. Then the support is from the word how we give someone to feel safe, connected, and understood. So mental health in responses is essentially to one, the patient themselves, the patient's family, their community, but also the person we often forget is the health worker. So mental health and psychosocial also is in rather there's an aspect for, okay. I don't see my slides anymore. I don't know.
Proceed with your presentation.
I can't see my slides.
Sure.
Let me present for it.
Oh, yes, if you can. Thank you.
Okay.
Yes, we can see.
Okay. I can't see. Jimmy, kindly.
Yeah, you can proceed.
I'm downloading.
We are downloading for you so that you can proceed with your presentation.
Yes, let me update a second.
Stop sharing from your side so that we can share for you here. Can you see now? Dr. Norbert?
Yes, please. Next, please.
Yes, kindly proceed.
Yes, next. Good. So for patients, the why we do mental health and psychosocial issues is, one, we have to give dignity to the treatment we give has to be dignified. Then you realize that the connection between mental health and psychosocial issue and physical illness is that regardless of the treatment you give, if a person is not in the right state of mind, they will not eat, they will not sleep, they will not adhere to your treatment. So if you deal with someone's psychosocial issues, you improve cooperation, and therefore you also improve treatment outcomes. Then you will also want to do this to prevent future mental health issues. For example, PTSD. Andrew has just talked about how we pick patients. Okay, so how you do it will also determine downwards. Then for us health workers, when you protect the responders, because without health workers, there is no response. So there has to be an element of supporting the persons who support the patients. And we'll have a slide or two at the end of the presentation. Then, of course, across the system. Next. Essentially, that's what we do. So, as I already mentioned, the patient, the family, the community, the health worker, mental health and psychosocial aspects are all for you. Next. Good. So, mental health and psychosocial issues do not start when there is an epidemic. It ought to start even before, by building capacity, as we are doing right now, by building resilience. So we train health workers, we go through communities, teaching them the do's and the don'ts in the event, in preparation for future epidemics. Next. So in the event that the epidemics come, we also participate in the response in terms of patients themselves in the treatment units, and then in terms of interacting with affected communities who are most often anxious, full of their rumors, their propaganda. Okay, so we also fill in that gap. Next. Next, please. Okay. Regardless, we know that when there is an epidemic, somehow it has to end. You either recover or you unfortunately pass on. Okay, like our patient. So for those who recover, we help the patient to reintegrate within back in the community, and we also follow them up in what we refer to as the survivors clinics. So that is even after the epidemic, we continue working. Next, please. Okay. For those who are unfortunate to not to survive, we in liaison with the self-burial team, we also participate with the community in giving persons or sending them in a dignified way in terms of burial. So that is this. You can see the scope of mental health and psychosocial management. So next, please. So what of the patient themselves? The gist of today's presentation is a patient who was suspected, then picked. While they were waiting for results, they were isolated. They were confirmed positive. Okay. Unfortunately, this patient passed on. See, so this is the life cycle of a patient. Okay. So from the time you are suspect, and they are going to pick you. Andrew and the team, the EMS team is going to pick you. There ought to be someone to prepare ground, because often you can imagine someone coming, knocking on your door and taking a loved one. So you have to explain to them in a very calm, dignified way the reason as to why they're being taken. Okay, not in a militaristic way, but in an understanding. Okay, even when they're isolated, you can imagine that time you're waiting for a result to come. Am I going to be positive? Am I going to be negative? The psychological trauma which is going through that person alone in their room. So someone has to stand in the gap and hold their hand, not literally, but be in their presence. Then, of course, daily care, as I'm going to elaborate a little bit more, someone has to give other support that is besides the physical elements of it. Then, of course, if they discharge you, we follow up. And unfortunately, if you pass on, we shall also follow you up. So from the moment a person is labeled as suspect to their outcome, whether they're discharged or buried, we are with you. We ensure that we get dignified and humane treatment at every step. Next. So let's, this slide is for what we ought to be doing in a treatment unit. Okay. What in vis-a-vis mental health and psychosocial issue, and rather psychosocial support. So ideally there is a ward round, and within that ward round, there is someone tasked to be in charge of the mental health and psychosocial aspect of the patient. So every morning, as you take the BPs, as you take the temperatures, as you take off blood, you also have to ask on the other aspect, how are you feeling? How did you sleep? What needs do you have? Who do you want to talk to? Okay. Screen each patient's mental state. And remember, mental illness is on a spectrum from mild, moderate to severe. Okay. You identify their needs. Basically, mental health and psychosocial issues are the needs that are not medical. Someone might be distressed with not talking to their loved one more than their fever and diarrhea. Okay. So connect them to their loved ones. It's spiritual needs. Do they want prayer? Do they want to ambulate? Do you want to talk to other patients? So you provide maybe a radio, you provide TV. Okay. Those small things actually matter to the patient. Then there will be the time you screen and the patient actually has severe mental illness. We are talking of psychosis, hallucinating, delusions, talking of suicidality, depression. Sometimes the patient is delirious, like this child, as we saw, got into confusion. The child was delirious. Sometimes delirium can be negative delirium, where a patient is catatonic. Refuses to eat, pulls out the NG tube. Okay, and such a patient is a danger to themselves, to others, and even to you. You can imagine a patient simply moving out or holding you. Okay, and then the outcome. When the patient is in the ETU and we're taking off these blood samples, do we come back to tell them, actually, the significance of this blood test is you're improving or you're becoming worse? Okay, you have to be open. Someone has to give them the news, whether good or bad. Okay, and if something is bad and we are seeing a downward trend, prepare for the worst. Have you set a will? Prepare the families. Some people want to, Catholics have a sacrament of the sick. So this all happens within the ETU, and this should be on a daily basis person-to-person assessment, and depending on the need is the mental the help that you're giving them. Next. So don't forget there are some persons with special needs, particularly, for example, children, like in this one, who was unaccompanied or separated. Okay. You can imagine a child who goes to nursery and is crying because of separation anxiety. But this one is with strangers. The elderly, pregnant, breastfeeding mothers who are separated, especially those who are separated from the children. You're in an ETU, you have just lost your loved ones, you have not had time to grieve, okay, you're still mourning the death, okay, then now you get bad news, okay. Then we also talk about persons who are intellectually disabled, cannot follow instructions, patients who are physically disabled that need help, need feeding, need toileting, okay. These are medical things that we do not take into consideration, okay? And of course, persons with pre-existing mental illness. And the common one is substance withdrawal. We have a big problem of alcohol, a big problem of, especially as medical workers, opioids. And now you're in the ETU, you don't have access to it. Then suddenly someone gets into a withdrawal syndrome. Okay? So we have to take all these in consideration. Next, please. So what are some of the interventions that we can do? Yeah, go on, please. So there is what we call a 4-tier intervention model, okay? Now, many people imagine that mental health and psychosocial issues is only for the PCOs, the psychiatrists, psychiatric nurses, social workers. No, we all have a role to play. Okay, the tier 1 is for everyone. Basic needs and security. Okay, it costs you nothing to ask your patient how they're feeling, what their need is. Okay, when we talk about social support, it is not counseling. That's what people think. If I'm hungry and I've not eaten the whole day, I don't care about my RBS, my whatever, brother, my CBC. My biggest problem is food. My biggest problem is I have not gone to the toilet. I'm constipated. So by solving that patient's problem, you are actually giving them some psychosocial issues. The next level is community and family support. Now, because of the nature of infectious diseases, you cannot have physical contact. So there's some creative way. You can use a phone, you can use, these days, the ETUs have a screen, the windows, okay? Just that connection of seeing a loved one can bring a bright smile or even improve their prognosis. When things become worse, that is when now you go to 3rd tier. You focus the non-specialized support. That's why you have counselors, the priests, social workers, okay? And then when someone has severe illness, like depression, psychosis, delirium, like in this child, that is when you now call the specialized patient. Ordinarily, we would refer, but you can't refer out of the ETU. So you would have the specialist coming into the ETU. And not everyone really goes to 4th tier. Okay, majority of needs are level 1, level 2, which we all can give. Next, please. Now, I won't go through this whole thing, but you will see when you get these notes that you'll find that when you read the examples of all these things, you can do all these things, okay? Maybe up to even tier 3, some of you, okay? So let us, I'm being an advocate for mental health and psychosocial issue. It is not only specialized, but you should also do your part. Huh? Next. This is the bare minimum anyone should know. psychological first aid. Okay, I think this should be taught in all medical schools at all levels, because this, just like they teach you how to stop bleeding, just like they teach you how to, the ABC, this is our ABC, okay? And it is a rather easy concept, okay? You listen, you link. So what does this mean? Whenever you see someone distressed, you cannot always tell. You've seen your friends struggle, you've seen your friends, and you've asked, are you okay? You're not in your mood. What you have done is that you have observed. So please be observant. And okay. Then listening is, if someone gives you a problem, doctor, I cannot, for example, I don't know what is happening to my children. I left my children alone. Okay. This is a mother. And your answer will be, don't worry, you first get better, then you go home. No, that is wrong. The major concern of the patient at that time is not the vomiting area. It's the children she left at home. Until you solve that problem, you're not actually treating her holistically. And where you cannot do anything, please link, okay? That is where there is always a mental health and psychosocial person embedded within the team. You can always make a report when you're debriefing and say, by the way, patient X said this, can we follow up? Where is her phone? She wants to read her Bible, or she wants to do this, okay? She wants to write a will. Who can help her? So those are the things you do, okay? Next, and this we can also do to our colleagues, okay? Because epidemics, especially those that are infectious in nature, do not only affect the patients. We are the frontline workers. I'll be corrected, but in almost all epidemics, a health worker has to die because we are the first line defense, okay? And unfortunately, we have been trained to be empathetic, okay? Yet we are not allowed to be human. We are like robots, empathetic robots. So regardless of that, this high pressure, remember you're being separated from your social circle as well. You are in a camp, you are told not to go, or you have colleagues who are your workmates who are in ETU or fear to have contacted, or you are working long shifts, you're brought in to man the ETU. So it will get, that toll will get on you, okay? So it is what we call emotional dysregulation, where you'll be moody, irritable. It will also start affecting you physically. It will be back pain, head. Just a second. If you go back just a bit, okay? You'll get what we call moral and spiritual injury, okay? Where you make life and death decisions, especially in resource-limited environments. Who are you going to give the last unit of blood? Who are you going to let die? Okay. So with time, you'll get PTSD by proxy, which means you will start having nightmares, you'll have the dead, you'll start having flashbacks. You'll then also start getting compassion fatigue. Compassion fatigue is when you get so exhausted, and then you start getting indifferent of the patient, and this will lead to a burnout. I've seen some of my colleagues get in severe depression, suicide, okay? Illness, anxiety, every small thing, every fever, every sneeze, you say, hey, am I infected now, okay? This can haunt you. And this is where some people now start taking substances, okay? Just to cope. Next. So as health workers, we need to take care of ourselves, okay? There is, I would say, 3 levels of care. The first person who takes care of themselves is yourself. Be self-aware of what you can handle, what you cannot handle, okay? Do not be driven by money. Do not be driven by being forced. If you feel you cannot do it, if you feel you're overwhelmed, please say it. It is not a mark on you. It's not that you're weak, okay? So please feel free to stop where you cannot, okay? Because if you do not, you're going to start making mistakes. And remember, mistakes in highly infectious environment can exploit all the rest. Imagine you have a mistake, you touch a patient, you forget, okay? That's how we get sick, especially when we are tired, burnout. So have your good sleep, eat well, drink well, regular breaks. We think we should not work more than one shift in a day. The second level is peers. Yes, please. I'm summarizing. This is the last. I think this is the last. All right, thank you. Peer support, daily check-ins, during the debriefing. When you're talking of the patients, also talk about your issues. Take some. Talk to a professional if you feel okay. Connect with your loved ones in terms of calling home. Pray. Okay. I think should be the last slide. Yes. So you remember, you're not dealing with a virus. Although we are isolating, we are dealing with a person, not a virus. The virus is isolated, but the human being remains human. So your response should have a humane touch to it. Mental health is not simply counseling. It is not a luxury. It is not something that comes in when someone gets depression. Mental health and psychosocial issue is across the spectrum of care. Every patient is more than a case. They are human beings. I thank you so much.
Thank you, Dr. Gumisiriza, for that wonderful presentation. Very informative. At this moment, we are going to have the next presenter. But meanwhile, to our participants, continue sending in your questions to our chats to be responded to by Dr. Chris. We are going to our last presentation. That is from
So thank you very much, moderator. Thank you, colleagues on the call. I'm taking you through the next lot of this presentation. Can we go to the next slide, please? So I want us to re-echo the general principles of optimized supportive care for Ebola patients. This is the approved, recommended WHO standard of care at the moment for all our Ebola patients. First of all, it is very important for us to ensure there is triage. This triage of the patient helps you to recognize warning signs and you deal with them immediately. In this optimized supportive care, we give ORS to all patients if they are able to take it. We give IV fluids if patient is in shock or if they are not taking in orally very well. Antibiotics for possible co-infection. We have to test for malaria, as most of these patients, their presentation mimic several other infectious diseases. And if we get malaria MRDT positive, we give antimalarials, or if it is unavailable, we still give antimalarial if patients are febrile. We need to correct electrolyte abnormalities. This has been very commonly seen in our patients with Ebola. Glucose inclusive is very, very important. We have to monitor our patients and manage warning signs and complications. We provide symptomatic specific treatment and just psychological support, which our colleague has taken us through. We also have investigational therapeutics that are available. And in case we are to use these investigational products, we need to always approach the patient, the parents, or an independent clinician for a consent for approved study or use on compassionate ground. This is very, very important that any investigational products being given or any research going on, the patient has to consent. If it is a child, we know what is to be done. Next, please. Now, triaging patients with Ebola viral disease is very, very key. Why do I say this? This is important because you are going to prioritize your care. And once that is done, you know that your outcome is going to be good. First of all, in this, the ABCD approach is very key, but there are danger signs or warning signs that you need to look out for. Once you have noticed that there is danger sign, this is a patient who is severely ill, critically ill, and the monitoring of this patient has to be 30 minutes to 1 hour until this patient is stable. This is very, very key. And immediately we need to place IV line or intraosseous to access supportive care. If there are no danger signs, that we shall look at also this danger sign. This is considered as mild disease. And of course, the monitoring will be every 6 to 8 hours. And of course, there are other general ETC management that this patient must be given. Next. So we can look at there are key intervention, 3 key intervention, which is life-saving management strategy for this patient. One is the design and biosecurity of the treatment center. Our treatment center should not just be an isolation unit, but it should be a unit that focuses on patients and their families and others. And also it should be a center which is can give high quality care to the patients and where staff are compliant with all biosecurity and IPC standards. Of course, the optimized supportive care, as you can see that guideline, that book, always helps to systematically assess our patients and give patients the treatment that they require. Then we have specific therapeutics. There are therapeutics which are approved and licensed, and this is basically from various studies that I will show you as we go on, mainly for Ebola Zaire. For other Ebola virus disease like Sudan virus, Bundibujo, and so forth, we still don't have any current approved therapeutics. All are being used on compassionate ground. Next. The same with Marburg as well. Now, with the therapies that has been proven, for Ebola Zaire, we have the MAP 114 and Regeneron. This is what WHO now recommends for the treatment of Ebola Zaire. And Marburg, Sudan, Bundibujo, we still don't have any approved therapeutics for them. But what is important in this case, it is that all EVD patients, the foundation of all therapies, optimize supportive care. And that is why in my presentation, I had to start with it. And without early diagnosis and high quality care, including monitoring of patients, the case fatality will always remain high. If you remember the 2022 outbreak, 2025 outbreak, there's been a very big difference. Most of the patients we managed in 2022 came late in their disease progress. But in 2025, most of the patients actually were diagnosed when they're in quarantine. And the monitoring of this patient has been very, very critical. And our survival rate for all the confirmed treated in the treatment unit has been 100%, which is something very good for us. Next. Now, we know that everybody actually deserves treatment that is effective, and that's the reason why WHO and other partners worked under clinical trial and eventually got those two monoclonal antibodies, the MAP114 and the Regeneron. But for the other viral hemorrhagic fever, Marburg, Ebola, Sudan, Bundibujo, we still don't have effective therapy. However, we are using MURI. MURI is monitored emergency use of unregistered intervention. And this has several names. We use compassionate, emergency use of outside clinical trial, expanded access protocol. This protocol, we actually have it. We experimented it during the 2022 outbreak. We again used it during the 2025 outbreak. However, as a country, we also have a clinical trial protocol, which we are ready to start in case we get another outbreak. This is going to be a clinical trial, and I'll show you the different therapeutics which we are looking at. Next, please. So the types of medication that we have the monoclonal antibodies, the antiviral, and the immunomodulators, such as corticosteroids. These are the therapeutics that are in the pipeline for studies, and the ones that have been approved already, I mentioned for specifically Ebola Zaire. For the rest of the Ebola strain, we are yet doing clinical trials to confirm whether they are safe and efficacious to be used. Next. So the monoclonal antibodies that has been approved for Zaire, the two monoclonal antibody Regeneron and MAP112, as we can see there, both of them actually have been recommended by WHO for use in Ebola Zaire. And they work by targeting the outer coat of the virus, the glycoproteins, as you can see from this slide here, where the MAP114 and the Regeneron is attaching to the outer coat of the virus. Next. So the antivirals for this is not yet recommended currently. And the immune modulators as well, we still don't have a recommendation for its use. You've heard about remdesivir. Remdesivir is being used conditionally. It has not shown efficacy in this trial, the PALM trial. The two monoclonal antibodies were actually did better than the remdesivir. And so the remdesivir, together with the other monoclonal antibodies that we shall look at, are now being tried to see whether they're efficacious on the filovirus, Marburg, and the other strains of Ebola. Move, next. So this is WHO antiviral recommendation for EVD for Ebola Zaire. It is still saying strongly recommended for MAP114 and then Regeneron for Ebola Zaire. And we can see down there in the remarks for each of them, the absolute mortality benefit from the studies. We can see for MAP114, it was 229 to 383 per 1,000 patients compared to the other. But these two monoclonal antibodies should not be given together. However, they can be used as alternatives. So the decision to choose which one will depend on what is available, really, for use. So let's say we have Ebola Zaire, we will be using the MAP114 and Regeneron to be given to the patient because it has already been licensed and it is efficacious and is safe, unlike the other molecules we are talking about. Next. So still it is giving us the WHO recommendation where we see remdesivir is conditional recommendation against, and the same with ZMapp and so forth. But all this, we have to say that the guideline is applicable to all adults, children, pregnant, breastfeeding person, and older persons. There is no one who's excluded. The moment you test positive for Ebola Zaire, we give you this medication. However, we need to monitor, and before we give you the medication, we have to ensure that you meet the criteria and you're fit to receive the treatment. Next. So there are new antibodies and the antiviral which are not registered. They are still under study, like I mentioned. At the moment, we have the proposed clinical trial protocol, which summarize 3-arm. That is an open-label randomized trial to look at the virus-directed therapy, where we have remdesivir, monoclonal antibody, MBP134, and then the host-directed therapy. In this case, we are looking at low-dose corticosteroids versus no additional treatment. And of course, at the moment, we have expanded access protocol under MURI. Why do we do this? This is because many times the clinical trials research takes a long time for you to get approval. And that's why this MURI concept gives access to patients receiving some of these molecules that we think can work. However, still patients need to consent for them to receive this medication. Next. So I've just put here the monoclonal antibody 134. This is a cocktail of human monoclonal antibodies, which has been taken from Ebola survivors some way back. And of course, this has been tested in animal models against Zaire, Sudan, and the rest of the other Ebola virus strain. So we think this can be tried on randomized clinical trial on our patients to see whether this is also the same. It can be safe, it is efficacious on human. So this makes part of the therapeutics that we are going to be testing come next outbreak. Next. So there are general things that you need to consider before administering these therapeutics. First of all, before the infusion of these therapeutics, we have to make sure that we are ready to manage the side effects of these drugs. And then you should be able to have the BP and SpO2 monitoring available. You have to look out for the followings before infusion, so that when somebody reacts to the treatment, you will not say, this is the drug, this is, when you have already noticed. It is very important that we look for these things. Like patient is having itching, they have a rash. This does not mean it's contraindicated, but you will be cautious because we know that some of these molecules, actually patient can react to them. Some people can get very high blood pressure, they can get very high temperature, they can actually get anaphylaxis, and so you need to be prepared to counteract these effects when you are going to be giving these monoclonal antibodies. Next. So we need to monitor and you observe. What do you observe and how often do you monitor? There are things that you need to observe. Next. Next slide, please. So we need to observe for the following. Look at the heart rate, the blood pressure, the respiratory rate, and oxygen saturation, like I mentioned. This is very, very important. You monitor the patient's symptoms and vital signs. How often do you do this? Next slide, please. So next, every 1 hour, it is very important that we keep monitoring this patient. And of course, before we administer this medication, we have to ensure that we have enough human resource, and you should be prepared before the infusion. So when you start the infusion, you must take the baseline of all the vitals of the patients. Then after 15 minutes of your start of the infusion, you have to monitor the vitals. Then 1 hour duration at the end of the infusion. So if the patient clinical situation deteriorates, you have to check, and sometimes you may end up even stopping this infusion. So you monitor the vitals, and please, whatever you find, you need to address it. No one will do it. You are not going to start the infusion and leave the patient. You have to be by the bedside of the patient until the infusion is done. And of course, afterwards, you monitor the vitals again. Next, please. So how to manage side effects if present? Next. You can see on this slide, there is a transparent screen. Those of us who are here on this call, who attended the simulation exercise, you remember the infectious diseases treatment model, where you can actually see the patient from the green zone. You can command the team from inside to do whatever intervention you want them to do to help the patient who is maybe reacting or has got an emergency. So for most common adverse effects that we see in these patients include pyrexia, tachycardia, the patient can vomit, and so forth. So when you notice this, you need to slow down the infusion rate. And if afterwards this continue, you might actually end up discontinuing the infusion, more especially if the patient develops infusion-related effects. And also for signs and symptoms of hypersensitivity reaction, for example, anaphylaxis. The moment you notice patient is getting anaphylaxis, you need to immediately discontinue the infusion and initiate appropriate medication. And which medication you need to make sure your adrenaline is there, hydrocortisone is there, antihistamine, oxygen, name it. All this has to be ready at the at the bedside of the patient with you, so that you can counteract the effects or the adverse reaction that has taken place. Next. So monitoring and recording, it is very important that the patient should be observed immediately for more than 4 hours after the completion of the administration of these drugs. And then we also encourage PCR to be taken 24 to 72 hours. We need to follow up the patient 14 days after administration of the products. And then there are follow-up 3 weeks after the product administration or discharge. You still have to follow up the patient. And if there is any severe adverse reaction, this is encouraged to be reported within 24 hours to the manufacturers, to the relevant authorities, so that it is taken on. It's like pharmacovigilance we do usually. Next. Of course, to the sponsor of any trial, you also need to, if it's a trial, you have to communicate to the sponsor of this trial. And many times patients are actually insured. Next. We are going to look at definitely if a patient is admitted, they either recover or die. If they recover, we have to discharge them from the treatment unit. And I want to emphasize here that in our country now, we use one negative PCR test. But before we take this sample for testing again, you must meet all the following criteria. One is that this patient must have 3 or more days without fever. Fever is very key in this case. Or any significant symptoms. For example, diarrhea, vomiting, and bleeding. These are the key symptoms that we look at. And this patient should have significant improvement in clinical condition and able to perform activities of daily living. Now, when the patient meets all the criteria, we can take the sample, and once the sample tests negative, we discharge the patient. We don't just write the discharge and we say, go home. No, we prepare the patient, hand them over to the psychosocial team who are going to reintegrate the patient back to the community. If the results come positive, I want us to know that sometimes symptoms may resolve, but it will take some days for the PCR results to be negative. And that is why anybody whose PCR is still positive will not discharge from the treatment unit. 48 hours later, we shall take the sample and test again. If it is negative, this is when now we can take you home through the same process I talked about. If you are positive, again, we wait for 48 hours. I've noticed that in 2022 outbreak, we were having people without symptoms. You take the sample, it's still positive, and so forth. And they were like, no, I'm okay, but you can't go home. We need to get you out when you have a negative PCR test. Now, let's say this person who is negative is a breastfeeding mother, and this mother has a child who is asymptomatic. Of course, this child is a contact, and they have been negative, let's say, for Ebola in case they had symptoms. The mother, of course, during her illness will not be breastfeeding the child, and when the blood PCR is negative, we want to do test breast milk PCR. We shall do that 48 hours, 2 times, and should have 2 consecutive negative breast milk PCR for the baby to resume breastfeeding if the mother wants to breastfeed again. I've seen some mothers, after they suffer Ebola, later they don't want to breastfeed their children again. But if they have a very young child, really, after testing the 2 PCR breast milk negative, they can resume the breastfeeding again. Next. So this is the references that you can read through. Next. Oh, thank you very much. This marks the end of what I prepared for you. There's a lot to talk about in Ebola viral disease or VHF, but the time can't allow us to talk on everything. The rest can be answered during question. Thank you very much. Any question and comments? Welcome. Over to you, moderator.
Thank you, Dr. Pascal, for that wonderful presentation and bringing out examples basing on the case presentation that was presented at the beginning. So next, we are having session discussions and questions to our participants. You've heard from our different panelists. They've taken us through case presentations that is related to our topic, which is approach to undifferentiated fever. So at this moment, we invite questions, and Dr. Chris Nsereko, consultant physician and Tebe Regional Referral Hospital, will be responding to the questions. By show of hands, I can give opportunity to like 4 or 5 people to ask questions. The rest we can send through our chats. As we wait for responses from the participants, I request Dr. Chris Sereko to, if there's any question that was directly asked for our panelists to answer, you can bring it out so that they can respond to it. Any question that is directly towards our panelist, Dr. Sereko? Yeah, we have Chirabo, Mika, Frederick. Kindly unmute yourself and ask the question to our panelist.
Okay. Hello, everyone. I'd like to appreciate. Actually, I don't have a question. I would just like to reach my appreciation to the entire team and raise my concern. I just have a concern to raise to the organizing committee of our CPDs that we always attend the CPD points and we have always given these complaints, but they have not been attended to. I think we are always not being added our CPD points, but we have been always attending and even to the end and even filling in the form, the last form for CPD points, but we are always missing out on the CPD points on our accounts. So we don't know how you are going to help us sort out this issue. Thank you very much.
Thank you, Frederick, for attending the sessions, and that is noted. It's being worked on. Next, I see Gillian Park. Kindly unmute yourself and ask your question. Gillian, are you there?
Let's launch the position for.
Next, as we wait for questions and discussion, we are going to our poll.
I couldn't unmute, but now I have unmuted. Is that okay?
Thank you. We can hear you.
Lovely. I'd like to say that every one of the talks today was exceptionally interesting and very informative all through. I wanted to ask the pre-hospital colleague, Andrew, I'm afraid I can't pick up the surname. He was talking about the excellent work that he does. How does that work get audited, was my question to him. Do the handover forms get audited? How does the system audit itself for continual improvement? Thank you.
Thank you very much, Gillian. Mr. Siri?
Yes.
Okiro, have you got the question?
Yeah, thank you so much. I hope I got the question right. I'll try to say what I heard. You asked whether we have a system that audits us. I can say apparently we don't have a sort of like a system that audits itself. However, like I mentioned in my last slide, that usually we do debriefs. So it is through that that we are able to evaluate ourselves, and most especially with those very challenging cases, near misses, or if there's a death, for example, and during those sessions of debrief is when we share such, and then the outcomes of the debriefs, depending on what the outcome amounts to, if it requires either changing the way of operating or improving on something that affects the entire team, then this can be put up for the entire team, or perhaps calling a bigger meeting, or then inform everyone on what perhaps is changing or what needs to be improved, or what has been brought new on board given the previous experiences. Or if it requires just only tying it to the specific team that responded to, still the outcome of the discussion can be tied to the specific team and support them to see how best they can respond to subsequent similar cases. Thank you. I hope I've been able to respond to you. Thank you so much. Over to you, moderator.
Thank you, Okiro, for responding to that question. Meanwhile, I request participants to continue responding to the poll questions, to the post-test, as we are almost coming to the end of the session. And so far, we have 70 responses to the poll post-test session out of 259. Let's continue answering the questions. And meanwhile, if you have any question from the audience, kindly let's raise up our hands and ask our question. We have Wangota Vincent. Kindly unmute yourself and ask your question to our panelist. Vincent? You're not clear yet.
Very much, moderator. Do you hear me?
Yes, we can hear you now.
Can you hear me?
Yes, please. Continue with your question.
Yes, hello?
Yes, we can hear you.
Yes. Yes, thank you very much, Miss. My is of a concern. The information brought on board. My view or my concern is going to giving holistic care at health. You may find that mostly those lower health facilities, mental health has been given a deaf ear in managing. And
summarize your question.
The staff, most of these health facilities, they don't is demanding for local governments and governments.
Summarize your
central
question.
Governments to issues.
Okay, we've not got your question, but as if you are asking a holistic care to the lower facilities, do you want to respond to holistic care to lower health facilities?
Holistic care.
Yeah, so though it wasn't so clear.
Yeah, because more of mental health.
Mental health.
Emphasizing the fact that mental health is always ignored.
So I encourage the participants, let's continue answering the questions. We so far have 101 out of 232. We have a few minutes to wrap up our session. As we are responding, answering the questions, at this moment, I would like to thank all participants for attending this session. And I request our panelists to give highlights of today's session. I'll start with the Dr. Sereko, who has been responding to the chat questions to give us the most answered questions and what really was his highlight for this session. Dr. Sereko, please.
Yes, thank you very much. I've been trying to unmute for the last 30 minutes or so, but I can't. Okay, thank you very much, Arima. For me, I think there are many questions that were asked on the chat, but I think the biggest one is when you have a patient, even the patient before he comes out of the ambulance, look even at the referral note. Ask what is wrong with the patient. Even before you receive the patient, even you receive before the IPC. So you determine the appropriate IPC to wear. So it's very important for us health workers, especially those working in emergency unit, to just get that glimpse of history. That's number one. Number two is about the therapeutics. The therapeutics are many. When I was working up country many years ago, we used to give hydrocortisone for everything. Bleeding, malaria, fevers, hydrocortisone. It used to be like a magic drug. But not in this. I don't think, as Dr. Pasco said, we give steroids in certain indications. Remember, this patient also has some form of immunosuppression. So when you load them with the steroids, you may worsen the condition. But again, which I wanted lastly is the psychosocial part, which Dr. Norbert handled very well. I think, Dr. Norbert, you'll come in your concluding remarks and talk about OCD. What is OCD in mental health? Or OCID. What is it in mental health? Because they have been asking me, but I wouldn't. But lastly, again, my participants, my heartfelt thanks to the participants who made it to the online platform, but also to my fellow colleagues who have been discussing this case. Remember always, when you're not sure, to consult. When you're not always sure as a frontliner, always consult. Always consult. So that at the end, you can see how many health workers were isolated on this simple case, which was there was a very high index of suspicion. Thank you, Arima. I do submit. Thank you, colleagues.
Thank you so much, Dr. Nsereko. That was a good highlights. And also thank you for responding to the chat questions. This moment, I welcome Dr. Pasca to give us her highlights for the day.
Thank you very much, moderator, and thank you, colleagues who are on this call and have stayed on call. There are some questions which were raised on the chat. For example, there was a question where, can the breast milk come back? And if so, this is very true. This infection usually is short-lived. We have seen mothers who are breastfeeding. Actually, the breast milk come back and they will have to choose. After meeting all the criteria that I mentioned, they should be having 2 consecutive breast milk PCR test negative, 48 hours apart. The breast milk can come back. Now, there is also a concern about ACT. Of course, when you decide this is malaria, you will treat as complicated malaria because this patient will have already all the clinical signs and symptoms of severe malaria. So you wouldn't consider giving them the oral antimalarials. You will go for IV artesunate in this case. There is also a concern that all undifferentiated fevers relate to VHF. Colleagues, we know that there are very many other conditions that can give you fever, but you need to approach fever very, very well, which we did not concentrate much on how you take history from a patient who has undifferentiated fevers. But there are a number of areas that you need to focus on so that you zero on a particular diagnosis and you investigate appropriately before things get worse. Otherwise, thank you very much for this session. Over to you, Chair. Thank you.
Thank you so much. That's a wonderful highlight. I think our participants have taken note of that. Dr. Gumisiriza, are you still online? You have that one question abbreviation of OCID. And briefly, in 1 minute, summarize for us, give us your highlights for the day.
Hey, yes. Thank you. I was not about to unmute. Thank you, moderator, for the wonderful work of moderating. OCD is obsessive compulsive disorder. In the context of what we're discussing today, you have, especially health workers, all means obsessive thought. Like usually it is the theme of cleanliness. Even after the responses, the health worker goes with that thought of germs everywhere, viruses everywhere. So they get into this habit of the compulsion is to wash their hands all the time, sanitize. Okay. So it becomes a disorder where they can even wash and even their skins they peel off. So my closing remarks are, as usual, I welcome everyone to interest themselves in mental health and psychosocial issues. Let us not be prescribing machines or drug dealers. We should also understand that the patient is a holistic person. When you prescribe, do they have what to eat? Are they sleeping? Are they okay? Okay. It's simple. Just take interest. How are you feeling? How are people at home? So that we give our patients all around care. And I thank everyone for the kind words in the chat. And I hope you'll be our advocates for mental health. Thank you so much.
Thank you very much for that wonderful closing remarks. Back to our in-house audience in seconds. Mr. Osiri, on the critical care aspect of it, your highlights.
Thank you so much, everyone, for attending. I will only emphasize on safety and safety first before we do anything. Thank you so much. Over to you, Chair.
Thank you. Mr. Kiroy?
Yes, thank you so much. I will also emphasize on communication and documentation. I encourage you to document and communicate even errors to the next receiving person. Often that's an error that people, sometimes intentionally due to fear, tend to avoid to document, and I emphasize this, just document. And lastly, always discuss the cases for quality improvement, especially challenging cases and those near misses or even death, and share with colleagues who are necessary just for improvement. Thank you so much.
Thank you so much. Thank you all our panelists for that wonderful remarks and closing remarks and point to note to our participants. And to our participants, thank you very much for always logging in to attend these sessions. And so far we have like 101 out of 235 participants who attended. Thank you very much. And in summary, of course, our topic for today was approach to undifferentiated fever, where we saw our case presenter, Alice. Thank you very much for taking us through the case presentation, and other panelists taking us through the presentations, which was very wonderful. And I hope it has really opened our eyes on how we approach patients with fever that may be not responding to treatment. We have 2 minutes to close. And I request all the participants to turn on their videos for photos. We have a symposium which is coming in and which is being organized by Emergency Medical Service. And it's be on from 7th to 8th. And topic will be on trauma, injuries, and emergency care. So our theme for that symposium is understanding the burden and impact of injuries in East Africa to improve emergency care preparedness, mitigation, and response. We request all those that are frontline health workers and whoever is interested to kindly apply and apply for the symposium that is coming in, so that we plan ahead and improve on how we can manage, of course, our patients with trauma and injuries as related to emergency care. Our videos, please. I can see a number of people there. We have Ambrose Okello, who has not yet turned his video on, but Tumwebaze Othman has not turned his video. Kindly turn on your videos. Yes. Hi, everyone. Thank you all for joining in. We appreciate your commitment towards attending this eco session. Commonians. Do you see that?